member of the UCT Global Surgery team. I have a background in anesthesia and global health and a real interest in supporting district hospital clinical teams at the coalface of our public service. That's you guys on this call. Now, this talk forms part of a much broader body of work, which you can explore on this YouTube channel. Here you will find an extensive list of extremely useful talks, custom-made for the district hospital setting. I'd encourage you to keep referring to them. I most certainly do, and we will be reflecting on many elements of these talks today. Today, we'll be discussing the framework for a safer anesthesia in your context. We call it the mantra. The mantra was born from an anesthesia training course called the Anaesthesia Launchpad. Dr. Rowan Dace, as Deb Bishop mentioned, is a specialist in anaesthesia critical care. He and I are the founders of the Anaesthesia Launchpad, but much of our work and content has been guided by what has been shared on this platform by David Bishop. And it's not only what he shares, but how he shares it. It has also been formed by our colleagues, many in the audience today at the district hospital setting, who have helped us to develop this curriculum for the Anaesthesia Launchpad, most of which has been done at the Eastern Cape. It's been really important for us to bridge content experts with context experts. We all share the goal of creating content, be it courses, guidelines, videos, articles that are relevant to the district hospital setting. We realize that for most of you, anesthesia is only a very small part of what you do daily. You are perhaps occasional or perhaps even reluctant anesthetists, and we realize that you are often put in difficult situations within a health system that is stretched and seldom offers a safety net. So our goal is to share this mantra tool as almost a lens to look through when you're approaching anesthesia cases and a framework around which to build a safer system of care. We'll introduce the process and revise some of the core concepts covered in these talks on this platform during this year. So there you go. This is the mantra. Note that it has 5 elements running clockwise from 1 to 5, starting with pause, prepare, do the basics right, expect common complications, and value recovery. Now, if you've listened to many of the talks on this platform, this will probably be familiar to you already. The point of the mantra is that it is a relatively simple tool with the goal of simplifying your approach to any anesthetic. Often anesthesia can become highly stressful, and we believe that if you work systematically through this mantra, you'll be able to organize your thoughts and processes, hopefully leading to better outcomes for your patients. Let's start with the first part, pause. Mistakes happen, and they most definitely happen more when we are rushed. This slide was photo taken from the talk that Bishop gave on crash inductions. It is true in this scenario, but also for every other anesthetic activity. Taking a little bit of extra time to pause is a valuable investment towards the success of your case. It's part of the WH surgical checklist. It's part of lots of educational teachings, and thinking about the elements that determine the type of anesthesia you're going to do, where and when you're going to do it, and who needs to be formed part of your team is an essential part of this. These are the things like, how sick is my patient? Is my patient fasted? What's the shock index? That's a term that would come up often. The shock index refers to the heart rate divided by the systolic blood pressure. If that is more than 1, we have a problem. Do the patients have a difficult airway? What exactly is the procedure? Where is the best place to do it? What anesthesia is the best and safest for my patient? And who do I need on my team? Who can I share the stressful scenario with? Pausing to think about these things early will save you time and trouble down the road. Next step. Prepare as well as you possibly can. You want to be focused on the full variety of elements here. You want to look at the patient, the environment, the team, and have a detailed anesthesia plan. Lots of these preparation elements are touched upon in the crash induction talk in September. And if you look at that talk, these issues are highlighted. We need to prepare our patients well by positioning them. If I can direct your attention to the bottom right of this page, by giving them adequate monitoring, working IV pre-oxygenation. You want to be preparing your environments well. Think about, does this need to be in casualty, in the ward, in theatre? Um, and this idea of stay and play, staying in your context in the ward or in the casualty, or to scoop and run to a better context is something we need to think about as we prepare for our cases. We also need to be sharing our mental model with clear role allocation throughout. And if you look at the top right, this was an example of detailed written plan of what we're going to do. In COVID, we did this very much verbally. We spoke through every step we were going to take before intubating patients. And that step of sharing your plan offloads the cognitive load and helps you share and make better decisions. All these elements are equally important. It does take a bit more time, but again, it's worth it. The more you do it, the slicker the process becomes. Moving on to step 3 of the mantra, do the basics right. And that's kind of one of the cornerstones of these talks, is just do the basics as well as you possibly can. For each form of anesthesia, there are basic steps that make your chances of success just so much more likely. These tips and tricks are shared in every one of the talks of the District Anesthesia Education YouTube page, but we'll discuss some elements here in a bit more detail. Obstetric anesthesia or obstetric spinal anesthesia. This is probably your bread and butter anesthesia, and it's a topic that, as you can see, if you look on the left of this page, has been covered often on this platform. It is an immensely important topic, and we are still not getting it right as often. In the wrong patients and not doing enough GAs when indicated. The complications often happen very quickly, and by far the best way to prevent these complications is by doing the basics right. So once you paused and you prepared as well as you could in steps 1 and 2 above, these are 5 steps that we want to encourage you to make part of your spinal habits, so much so that it becomes muscle memory. Place the wedge under the patient's right hip, co-load with IV fluids, cycle the BPs often until the patient stabilizes, early phenylephrine, and stay in constant contact with your patient, including checking the level of the surgery. For more details on these steps and the rationale behind them, please look at the videos and articles suggested here on these slides. This is an article from the South African Family Medicine Practice, and there are more videos as mentioned. Crash inductions have similar steps, each valuable ways of keeping your patients safe. Print this out, put it on your wall, put it in the wall in your casualty. Following these steps will really help you. The GA itself is something that can be immensely intimidating, especially if you do it every now and again, 3 o'clock in the morning. I want to encourage you to look at the videos referred to here and to think of the 4 basic steps to help you prevent desaturations, one of the most common concerns around general anesthetic. Position your patient slightly ramped, pre-oxygenate well, consider negative pressure oxygenation and ventilation. These are things that specialists need to just do every day. And we at the district somehow make our lives difficult by not doing it. Remember, local studies have shown that 1 in 6 patients desaturate below 90% during intubation. Of course, a GA has various elements. It can be simple or it can be complicating. I'd like to therefore encourage you to use resources such as this flowchart on how to do a GA for rapid ectopic pregnancies. There are lots of tips here that are translatable to many forms of GAs, particularly the patients that are unstable or that you worry about in particular. Now, it's not just about spinal anesthesia, general anesthetics, crash inductions. Sedation forms a big part of your anesthesia services, if you believe it or not, at district hospitals. We often, and this is a term that's come up in these talks before, we say we're just going to give some ketamine. We're just going to give a little bit of sedation. Sedation is often referred to as the dark arts of anesthesia. It can be extremely hard, and be cautious. I'd therefore like you to use this mantra in your sedation context as well. And in fact, those easy sedations, it's a good way of using this mantra often. There are many useful videos on the platform, including a sedation for evacs, which I haven't included here. Use the resources as in the top right corner here. The SASA guidelines for 20 to 25, very useful if you want to understand sedation better. It gives you some dosages. It helps you set up your sedation space, helps look at recovery. It's a very useful tool. The basic take-home messages, though, are respect sedation. Titration eliminates guesswork. Anxiolysis is not analgesia. And keep it simple. Do what you know to start with and build on that service. If you're just using ketamine, do that and move on from there. Slide 4, moving on to step 4. Expect and manage complications, both the common ones and the severe ones. We trust that having followed the mantra up until this point, you would have avoided many of these complications from happening in the first place. That said, it's always good to keep these in mind. Having an approach to complications such as these mentioned above is essential. In particular, hypertension, for example, happens often, and high spinals doesn't happen as often, but it can be incredibly severe. We spoke about desaturation during GA. Think about having something like the Difficult Airway Society's algorithm stuck up in your theatre to help guide you. And then sedation, remember, it can be something very simple, it's like anxiolysis, but it's a continuum, and patients can slip into apnea or loss of consciousness or even cardiovascular instability. So don't underestimate it, as I was saying earlier. Use the system. Think about these things as you are pausing, as you are preparing, as you are doing the basics right, that you can prevent these complications from happening. And if any of these topics don't look familiar or you don't feel you have a handle on them, do read up on them. Do spend a bit of time discussing it with your colleagues, or perhaps even doing a talk on it. There are lots of various useful context-relevant resources like these 3. There's a great management of high spinal anesthesia article in SASA, on the SASA guidelines on the website. That's easy to get hold of. There's a high spinal video, and there's an article called Troubleshooting Obstetrics Spinals that has a lots of interesting little tidbits. Lastly, value the recovery period. When all the hard work is done, the tricky airway was managed, the stubborn bleeder was controlled, you really want to not mess it up kind of as you cross the finish line. Please do not undervalue the recovery period. Our patients are still extremely vulnerable in this period, and sending them back to a ward where they might not have good monitoring, where they can get lost in a corner, that really leads to troubles and pushes our perioperative mortality up tremendously across Africa. So value this recovery period, whether or not there's a space or person, never mind protocol for recovery. It just seems to be quite random at many hospitals. I know it was in the Passage where I worked in the district, and the reality is that we need a dedicated recovery space that is staffed, equipped. Think about if you need to do a crash induction there. Do you have the equipment for that? You want to have clear discharge criteria, that everybody's on the same page as to when these patients can go to the ward, and there are many guidelines for this as well, including in the SASA guidelines. You want to have a good plan for analgesia and nausea and vomiting. And you don't want to be moving on, if you're in a limited staff setting, to do the next case if you can help it until this patient is recovered. So, for example, post-spinal, you want to be administering oxygen, monitoring the BPs and SATs regularly. At Mowbray, we did that every 2.5 to 5 minutes. Make sure the patient's not bleeding. Make sure the patient is adequately analgesed. Infuse your oxytocin over 8 hours, and then discharge once the level has dropped. We used to say T10 or by 2 segments, and your vital signs are not only normal but stable. Having a system like that will really save you from running into trouble in the wards. And I suspect many of you can think about that case that post-operatively you had to go and rescue in the ward. All right, so this is the mantra in its entirety. I'd like you to see it as a tool or a lens through which you can use and systemize the knowledge you already have. It's the idea here is that it just gives you a little bit of a tool to do these 5 steps well. You might adapt it to your context slightly differently. You could argue that you want to do a pause after every single step, and that's very, very real. But the reality is that in the district, you are doing anesthesia much less common than somebody who does this every day, all day. We therefore feel it's super important that you have a bit of a system that catches you when things go wrong, that makes you feel a little bit less alone when you're out there at 3 o'clock in the morning. So try it, adapt it, let us know how it works for you and how we can improve it. And let's see if we can try and make the care we give our patients at the district that little bit safer every day. I just want to again emphasize the useful resources that are out there. All the videos on the district anesthesia education, they are specifically designed to be practical and relevant to your context. You want to be looking at things like articles for rupture ectopic and the troubleshooting spinals. There's great ESMO guidelines. Look out for the Anaesthesia Launchpad coming to your area, and reach out to us if you want a workshop like that in your district. And then there are also other good courses. There are lots of people doing similar work around safe OBS and safe PEDS, and adapt what works for your context. But as mentioned, please reach out to me. That's my email address there at the bottom if you have any questions or any concerns. And yeah, just thank you so much for your time today. Thank you for taking a moment to look at this. I hope we've refreshed some core concepts and given you a bit of idea of maybe a framework or a infrastructure on which to build the knowledge you already have.